CT calcium score, a clinical guide to benefits and risks. The coronary artery calcium, CAC, score is one of the most powerful tools currently available for cardiovascular risk stratification. Understanding exactly what it offers, and where its limitations lie, is essential for making an informed decision about whether to have one. What the test actually measures. A CT calcium score is a non-contrast, ECG-gated CT scan of the heart that quantifies calcified atherosclerotic plaque within the coronary arteries. The result is reported as an Agatston score, a weighted measure of the density and area of calcification across all major coronary vessels. It is not a functional test, it does not measure blood flow, provoke ischemia, or identify soft, non-calcified, plaque. What it does exceptionally well is quantify the total burden of established atherosclerosis, giving a snapshot of cumulative vascular damage accrued over a lifetime. The scan itself takes under 15 minutes, requires no contrast dye, no exercise, and no pharmacological stress. It is one of the lowest complexity cardiac imaging investigations available. The benefits. Powerful prognostic stratification. The most compelling case for the CAC score is its prognostic accuracy. Data from the multi-ethnic study of atherosclerosis, MESA, one of the largest and most rigorous cardiovascular cohort studies ever conducted, demonstrates a graded association between CAC and 10-year ASCVD event rates across all age groups, sexes, and ethnicities. A CAC score above 100 universally identifies patients with a 10-year ASCVD risk of at least 7.5%, irrespective of what traditional risk calculators suggest. It provides greater incremental predictive value than polygenic risk scores as it shows how much calcified coronary atherosclerosis you actually have. The power of zero. Perhaps the single most clinically useful application of the CAC score is its negative predictive value. When the score returns zero in such a patient, it supports deferring statins, a meaningful, evidence-based de-escalation that avoids years of unnecessary medication, side effects, and cost. The zero score is not an absolute guarantee. A CAC of zero does not mean zero coronary artery disease. It means zero calcified plaque, but young patients with early atherosclerosis may have predominantly soft, non-calcified plaque that is invisible to a calcium score but still capable of causing an acute coronary event. In symptomatic individuals, a CAC score of 0 provides false reassurance and should not be used to rule out obstructive disease. That is the domain of CT coronary angiography, CTCA, or functional testing. The power of 0 is most valid in asymptomatic patients for primary prevention risk stratification. Risk reclassification beyond traditional factors. The CAC score consistently reclassifies patients both upward and downward when added to standard clinical risk tools. This is particularly valuable in 3 groups. 1. Intermediate risk patients where statin initiation is uncertain. 2. Patients with strong family history of premature CAD but otherwise low clinical risk scores. 3. Younger patients in whom traditional risk calculators tend to underestimate cumulative lifetime risk. Identifying very high-risk individuals. At the other end of the spectrum, a CAC score greater than or equal to 1000 defines a distinct phenotype of extreme atherosclerotic burden. These patients have annual cardiovascular event rates approaching those seen in secondary prevention cohorts, people who have already had a heart attack. Identifying this group allows clinicians to escalate therapy aggressively. High-intensity statins, blood pressure optimization, aspirin consideration, and potentially early referral for specialist cardiology review. Without the CAC score, these individuals might be labeled high risk on clinical grounds, but the CAC concretely quantifies just how high the risk is and motivates both the clinician and patient to act decisively. Risks. The calcium score only shows calcified plaque. The younger you are, the more likely you are to have non-calcified plaque without calcified plaque. The calcium score also does not tell you if you have plaque elsewhere. It should not be the only test performed if you have symptoms, as its sensitivity in these situations is poor. Radiation exposure. Every CT scan involves ionizing radiation, and the CAC score is no exception. For women, particularly those under 50, this radiation risk deserves explicit discussion before proceeding. The total dose can vary widely depending on protocol but is typically similar to a few months of sun exposure. The dose is meaningfully higher in patients with a BMI above 30. Practical takeaway. The CT calcium score is a robust, reproducible, and remarkably information-dense investigation for the right patient. An asymptomatic person in the intermediate risk zone where clinical risk calculators leave genuine uncertainty about preventive therapy. Its strongest evidence is in the power of zero, giving patients and clinicians confidence to defer medications, and in identifying the extreme high-risk phenotype where aggressive treatment escalation is warranted.